Thank you very much for the invitation to come to Jena to give a talk about Mimetherapy. I'm sorry not to speak in German, but my German is not good enough. So I'll do it in English, also not my native language. Ich spreche schon ein wenig Deutsch, so wenn Sie eine Frage stellen möchten in Deutsch, dann kommt es auch schon gut. I'm from the Netherlands, from Nijmegen, the oldest city in the Netherlands, more than 2000 years old. I visited it, and I worked for 40 years in the university hospital as a physiotherapist. I'm officially retired, but I still see patients from the facial team in a private practice. I would like to say something in this presentation about what is Mimetherapy, some words about our facial team, and some words about the research we have done. In between you see several masks, and it's a personal hobby to collect asymmetrical masks. Mimetherapy is developed in the early 80s. By Jan Bronk and Pieter de Vriese. And Jan Bronk was a mime actor and director of the Dutch Mime Center. Pieter de Vriese was an otolaryngologist. And I would like to show you a small part of a video made from Jan Bronk. And he had a very good control about his mimic muscle. And I would say, try to do it yourself. That's what you see on the screen. After an intensive contact with Jan Bronk and our physiotherapy department, Mimetherapy became a combination of mime, physiotherapy, and in the later stage, also items from the speech therapy were added. So the content of Mimetherapy, in short, is an extended intake, advices for the patient, massage of face and neck performed by the patient, carried out by the patient himself. And you all know that a facial palsy can cause a lot of stress, of course. And so some patients, we need breathing and relaxation exercises, basic exercises between both half of the face, coordination exercises, exercises to reduce synkinesis, word and letter exercises, and last but not least, expression. The use of expression and emotions is very much used in Mimetherapy. So for example, you can ask a patient to raise your eyebrows, but you can also ask how you look if you are surprised or if somebody is telling you something very odd. And that can give another reaction in the face. A vital part of our communication are emotional expressions, and they are not only expressed in the face. So you can use your hands, your shoulders, and even your whole body to express something. So patients can make use of body language, and if you use that, it detracts attention from the face or the facial palsy. And that can give another reaction if you are in communication. So the loss of emotional expressions gives a less quality of life, of course. It can give a less integration into social network, impaired interpersonal relationships, but also can occur that you have social distress and social isolation. Do you have any idea which expression this young man shows? He has a right-sided facial palsy. You don't, yeah? No, no, no. And so if you're sitting on the right side of him, you don't see what he wants to show. Yeah, he's surprised, or yeah, he's raising his eyebrows. And instead of, for example, frowning, you can also teach a patient to use the arms and to express being angry. And it also helps if you feel the emotion, if you think about an emotion. And so, for example, if you smile, think about something funny or good friends. That also helps your emotional expression. And Charles Darwin already explored emotions 150 years ago, and he saw that worldwide there were 6 basic emotions more or less expressed worldwide, and that is happiness, disgust, surprise, sadness, anger, and fear. And these basic emotions we also use in Mimetherapy. But in short, we divide Mimetherapy in 4 stages. The paralysis stage, so no movement at all. Plastic paresis, synkinesis, and post-surgical rehabilitation. I'll go through all the stages. In stage 1, we have an extended intake, and that's also the same for the rest of the stages. And what you want to know, of course, is demographic data, but also data about the palsy, when it happened, when the first movement came back, but also complaints about eating, drinking, speaking, quality of life, stiffness in the face, etc. And as measurement instruments, we use the Sunnybrook scale, the House-Bachmann scale, and the House-Bachmann scale, because if you want to publish some things, sometimes they want you to divide the patient in House-Bachmann scales. The synkinesis assessment questionnaire and the facial kinematic evaluation, and also, of course, photos and videos. Yeah, we see the patients already in acute phase, and mostly, yeah, not very often. If there's movement coming back within 4 weeks, then you know the prognosis is good, so we see the patients 1 or 2 times. But what we are doing is a lot of education, so what is happening, what's going on, and in our hospital we have much more time than the doctors to explain things for the patients. We give advices, so eye care, what you see here, or during the night, but also adapted glasses, tips for eating, drinking, speaking, talking, tips for emotions. And we teach the patient the massage, carried out by themselves, stretching the upper eyelid for temporary better closure, so especially for before they're going to sleep. And sometimes a tape, especially in more elderly patients, when, for example, the mouth is, the corner of the mouth is hanging very much, and so talking gives a problem, or in an ectropion under the under eyelid. In the stage 1, we don't give movement exercises because there is not yet movement. We wait till there is re-innervation, and we see a little movement. So when tone is coming back, movement is coming back, then we go to stage 2. And in this stage, we're doing the basic exercises, so to teach what kind of movements you have. Coordination exercises. What is important is to make small and very slow movements, guided by the unaffected side. And we also make use of expressions. Well, an example here of the exercises of the lower lip. What we also use is mimicking. Well, you all know that. We all use it mostly unconsciously. If you see somebody yawning like here, then you easily tend to yawn yourself as well. This means that as a therapist, you can demonstrate a movement and the patient have to mimic or to copy that. The consequence is that as a therapist, you have to know exactly what you are doing, that you make a good movement. And in children, you can make use of drawings and all kinds of things to make a little bit more fun out of the therapy. What we also use is we call it a double mirror. What you see here, so this is a mirror and this is a mirror. So the patient watched in a mirror with his unaffected side, and then he sees a perfect symmetrical face. This is a boy, and we ask him to smile, and you see the asymmetry. He has a left-sided facial palsy. When we did the same exercise in the mirror, you see a much better smile here. That's in the same session. It's not helpful for every patient, but sometimes we try it, and sometimes it helps very well. You're cheating your motor cortex, and that gives a better reaction back to your face. Stage 3 is synkinesis, and this drawing we use for the explanation to the patient what a synkinesis is, because most patients don't have a clue in the beginning what's happening in the face when they have synkinesis. And synkinesis can be very complicated. What you see here, well, you see immediately, of course, on what side the facial palsy is. Who is saying the right side? So the right side of the patient. Who is saying the left side? Yeah. It's the left side. Here she's trying to make a pout. And you see synkinesis of the eye. The eye is nearly closing. And you see also synkinesis of the platysma. Here she's trying to smile. And you see again synkinesis of the eye, but there's hardly any movement of the corner of the mouth. But if she's closing her eyes, there is movement of the mouth. So the synkinetic movement can be stronger than the voluntary movement. Something else in synkinesis is that you don't have to confuse it with associated movements. So for example, if I lift my upper lip, this, and I do it very strongly, like this, then you see an associated movement. And when you ask the patient for a strong movement, you don't see the synkinesis anymore. So that's why always one of the reasons why you make a slow movement. There are two issues in synkinesis. There's an increased muscle tone, and there's an abnormal motor pattern. So for the increased muscle tone, we use massages, stretching, heat sometimes, and for the abnormal motor pattern, we use inhibition of the antagonistic groups, and also isolated muscle contraction. Now, this is an example of a lady who is stretching. The stretching can be very painful in the beginning because it can be very stiff, that side. But if it's stiff, it's very hard to move it. So you cannot make small, gentle movements if the face is very stiff. So we always start with that. Here you see a patient just after 1 day, and it's still not gone, of course, but if you see there's a high tone here in his face and in the platysma, and after 1 day, so I think 2 times stretching, half an hour, there is more relaxation in the face, more relaxation here in the platysma, but also here in the cheek, in the eye. So most patients are very grateful for it because it helps a lot. But you know, of course, that if you see synkinesis, there's never 100% recovery. That's not possible because there is denervation then. So the treatment in synkinesis it's a more or less post-acute rehabilitation. It is sometimes new learning versus spontaneous recovery, and it's more coordination, precision, and not strengthening and mass movement. And of course, patients have to do a lot of homework. So patient education is also very important. The more the patient knows about where the muscles are, what the muscles are doing, what the synkinesis is, etc., it helps to understand what they have to do. And yeah, we make use of functional patterns, so not maximal efforts, and functional movements, low amplitude, precise, and very slow. And here you see an example, pre and post therapy. Another example, pre and post therapy. So this was in the beginning, and she's making a smile, a big smile. And if you make the smile a little bit with less effort, you see that she can keep her eye open. And there's less synkinesis of the platysma. So it's not over, but better. And sometimes we make use of a manual support as well. So a manual touching, so to feel the difference between both sides. And that sometimes helps as well as a sensory support to keep more control over the synkinesis. Well, another example, pre and post. Here she's trying to make a smile. You see a lot of synkinesis in this lady, the eye, platysma, chin. And here also as well, the zygomatic muscles. And if you do it more relaxed, it gives much more a normal tone in the face. I will not say much about post-operative phase, but as a therapist, it is very important to know what kind of a surgical procedure has done. It makes a big difference if there, for example, is a hypoglossal jump anastomosis or a temporalis transposition or a mesenteric facial anastomosis. And that gives another swing to your therapy, so to say. Well, some words about the facial team. We have a facial team for at least, I think, 15 years in the Radboud. It's a multidisciplinary team and consists of an ENT doctor, a plastic surgeon, a speech therapist, physiotherapist, and a psychologist, which is here, and there are also some residents here. And there's a consultancy morning twice a month, and we see about 150 new patients a year, and it's more for the complicated patients and second opinions. And we see the patient all together, and together with the patient, we make a treatment plan. And the good thing about such a team is that you learn a lot from each other. Well, also some words about the research we have done. For my PhD, I have carried out a randomized controlled trial with patients with a long-standing facial nerve paresis. So for patients having a facial palsy a year or more, to exclude spontaneous recovery. And what we saw after the therapy, that there were a significant improvement concerning the symmetry of the face, less synkinesis, better functions of eating, drinking, and speaking, and less psychosocial problems. And as a mean, patient improved 1 greater House-Brackmann scale or 20 points on the Sunnybrook scale. Yeah, and what will the future bring? More e-health? Yeah, especially in Corona time, I think. Yeah, Skype, 3D. What you see here is a lady not having a facial palsy, and she is closing her eyes. And this lady has a facial palsy on the right side, and you see if she's closing her eyes, that the mouth is moving. So the red spot gives the movement, so the synchronesis of the mouth. And so after therapy, you can see if the red spot gets smaller, or after Botox, for example. But there will be much more coming up, and that's good, of course. And I hope there will be more research as well. And then we're coming at the end of the presentation, so maybe there are some questions.
Yeah, a lot of the questions in the chat are very detailed, so I don't know how much they bring us forward. Is there a recovery expected after 3 months? What can I do to improve my taste? What would you recommend if the corner of your mouth has some tickling feelings? So I have tried to answer some of the questions already, but if you have some ideas about taste or strange sensations.
No, concerning the taste, my experience is that mostly it's coming back. Yeah, and you cannot do anything for it. No. Well, the other side, of course, has a taste. So yeah, if you want to taste something, then try to eat on the other side, I would say. Yeah. And concerning the tickling, mostly is that there is still some recovery in the face. Yeah. 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 Yeah.
Can you give some insights for families with children with congenital palsy? So what do you do what do you advise families with children with congenital palsy?
Yeah, small babies, because the biggest problem in babies is, of course, the feeding problem. And in a hospital, they are going to a speech therapist because they have a special program for feeding babies. And for Mimetherapy, we see children from 4, 5 years and older. Yeah, and then you start, of course, with very simple exercises, and we teach the parents how they have to do it at home, and then more in a play form, I would say. Yeah. But you can start very early with children. Yeah.
So who should they contact to get this advice? Because we are very focused on adults, not very much on children. Facial palsy UK.
Yeah.
Come to you.
Or I don't know if there are speech therapists here who are working with children. Yes?
Yeah, there are, but not too easy to find who specialized on it.
Yeah.
Yeah, it's the question where to send them.
Yeah. And I know that in Belgium, there's also somebody who's really specialist in children. She sees a lot of Lisbeth Smet in Ghent. She's seeing a lot of children. Yeah.
And so I think what we see here again is that this network is missing.
Yeah, there are, but there are nowadays. We made a guideline. It's not. It's more a multidisciplinary guideline for children with facial palsy. You can find it on the internet. If you type in guidelines facial palsy children, then you will find it. Yeah. And at the moment, we're also busy with making a guideline for adults. Yeah. So there's an international group who's doing that. Yeah. So, but well, it will take more than a year, I think, before it's ready. But okay.
Is the help of the European Union?
Sorry?
Is it with the help of the European Union, if it's international, or which level is it? Was it the Third Class Society?
No, the most colleagues are members of the Charles Bell Society, but it's initiated from the UK. Yeah.
Okay, because the UK,
yeah.
They are strong strong
yeah.
societies.
Yeah.
Thanks very much for your talk.